And no other intervention touches so many lives. Just as I've been talking here, there have been thousands of vaccine doses that have been administered around the world. On average, 30 vaccine doses are administered every second in the world. But then we now have a problem. There's a rising hesitancy against to vaccinations. And it has not started now. In around the time that Edward Jenner started with using cowpox to do vaccination, there was this cartoon that came up where people were showing that when you took the cowpox, the vaccination, you were going to turn into a cow. And you see how they're showing people turning into a cow. So of course, nobody turned into a cow. They just wanted to frighten people. And just recently, because of the rising cases of measles in the United States, some states like the state of Washington have now mandated vaccinations, so it is obligatory to get measles vaccination. But there have been protests. There is one of these protest pictures showing where this lady is saying that, keep your needles away from my child. But what I want to tell that lady is, I keep that needle away, you should be ready to go to the mortuary with that child. Which one do you prefer? And so vaccine hesitancy has been, the strategic advisory group of experts on immunization had a working group in the beginning of I think it was around 2012, to look at issues around vaccine hesitancy. And this group defined vaccine hesitancy as a delay in the acceptance or refusals of vaccines despite availability of vaccination services. And they said that vaccine hesitancy is complex, and it is context-specific. The issues that drive vaccine hesitancy in Nigeria are not necessarily the very ones that drive vaccine hesitancy in South Africa or in the United States. And they vary across time, across place, and across vaccines. And I just want to show some of the cases of vaccine hesitancy issues that we have had in previous years. And one, I'm sure I will ask my friend, Abdu Adamo from Kano. He will, if you want any more information about what happened with the boycott of the polio vaccine then in Kano and the northern states. And unfortunately at that time, there was an importation of polio to many countries in West Africa. And we have not been able to, I don't think we have actually recovered from that. But I'm sure we'll do that very soon. And more recently, we've had various measles outbreaks in Europe. We now have the cases that are 20-year high in the US, and these are places that have already eliminated measles, just because people are hesitant. And that is why vaccine hesitancy has been on the spotlight. I just talked about the working group on vaccine hesitancy from the Strategic Advisory Group of Experts on Immunization. They had this report in 2014. Yearly now, there's the Global Vaccine Action Plan, and I think this was mentioned when they were introducing Professor Ampofo. And there is an annual report from the Strategic Advisory Group of Experts on Immunization, and they always call for, like the 2018 one says, there is a need to better understand the drivers and barriers to vaccination uptake, and to build national capacities to develop and implement tailored strategies to promote demand for immunization. And at the beginning of this year, the World Health Organization named 10 greatest threats to global health, and one of them was vaccine hesitancy. In my group, we have, over the last 1 year, because of this increased attention on vaccine hesitancy, we have tried to synthesize the evidence, because in our unit, what we do most is doing systematic reviews. And systematic reviews is about synthesizing evidence on what we currently know. If you don't synthesize evidence on what you currently know on a topic, and you are doing any research, you might just be reinventing the wheel. You might just be doing what is already known. Unless you synthesize evidence on a clearly defined question on whatever topic it is, you will not know where the gaps are, and you will not know where we already have enough evidence. And that is why we've done in our group, in terms of synthesizing the current evidence on what is known and where the gaps are on vaccine hesitancy. So what have we found? We've found that, okay, I think I missed it. We have found that there have been a lot of over the last 5 years or so, there have been a lot of conceptual models to try to explain vaccine hesitancy, what it is and what determines it. But what I want just to highlight here now is from the SAGE Vaccine Hesitancy Working Group, where they said it is affected by things like confidence about trust, convenience, and complacency. And they showed that vaccine hesitancy actually, when you look at any vaccine, there's a large number of people who would accept the vaccine, a small number who will refuse the vaccine irrespective of what you say. And then there is, in between, a continuum of some who accept but are not sure why they're accepting that vaccine. Some delay the vaccine, they accept some, but they don't take some. And then there are some who refuse, but they're not sure why they're refusing. And that has now been developed by another colleague from Effort in Germany, who says that this is that it is confidence, complacency, and convenience, but that also there are other things that add up to that, like calculating risk and also collective responsibility. If you want to know more about that, send me an email. So what we have found is that vaccine attitudes, decision-making, and behaviors exist along a continuum. It's not just a simple people who are pro-vaccine and those who are anti-vaccine. That vaccine attitude, decision-making, behaviors are shaped by complex psychological, emotional, social, political, and ideological factors, and it's not just because of ignorance. Actually, we find that most of those people who refuse vaccines, some of them are highly educated, and they have their own reasons why they refuse them. And that understanding vaccination attitudes, decision-making, and behavior requires a multidisciplinary perspective, taking disciplines that are beyond epidemiology and medicine. We've also found that there are various gaps in terminology. People use a lot of terminology very inconsistently, where at times they call this confidence, they call it hesitancy. And there are too many conceptual frameworks. Few of them explain how the determinants operate and interact. And the terms and frameworks used are predominantly from research conducted in high-income countries. We've heard that already here. We need to wake up in Africa. So there have been various advances too in the development of tools on how to measure vaccine hesitancy. And most of those tools also have been based on work that is done in high-income countries. And here I've just shown why it is important to have the tools to be able to detect concerns early, to monitor trends over time, to understand hesitancy levels and correlate, to differentiate hesitancy from the various other reasons why people are not vaccinated. And my friend Abdu is going to talk tomorrow about missed opportunities for vaccination, which is also a very important cause of under-vaccination. And also, if we have tools, we are going to be able to compare the results over time and also between countries. And it will also improve quality. And if you are able to measure it, then we'll also be able to develop evidence-informed interventions. So that's why at our unit, we have this program on social and behavioral program, where our aim is to generate, synthesize, and disseminate evidence-based knowledge on the social and behavioral drivers of vaccination to inform immunization programs in South Africa, in Africa, and also globally. And these are some of the specific objectives. We are also doing quite a bit of evidence synthesis. We've done some, but we are also, these are two Cochrane reviews that we are looking about what influences the uptake of human papillomavirus vaccination, what influences the uptake of childhood vaccines. We're also doing a bibliometric analysis trying to see where research has been done and what influences research on vaccine hesitancy. One of my other students is also looking at the tools that are available for measuring vaccine hesitancy, and another one is looking at the views and experiences of HPV vaccine in Africa. But we are also doing primary research, and one of the main programs that we're working on now, we're hoping to get money from the Wellcome Trust, is that we are working with various countries in Africa, in Nigeria, in Kenya, in Cameroon, and of course in South Africa, trying to develop various scales for measuring vaccine hesitancy and trying to understand whether we can have a specific scale for each country, or if the determinants are common enough for us to be able to have scales to measure this across the various countries, the 4 countries, and maybe if we can extend this to other countries. And we are going to use this also to build capacity in social and behavioral research around vaccination. And I thank you. Ngiyabonga. Danke.
Aha, Nkosi. Merci beaucoup. Obrigado. Okay, so you've listened to another presentation that's related to Professor Williams' presentation, I would say, because it's on vaccine and now vaccination, the uptakes, the hesitancy, and all of that. Do we have questions for him? I'm sure we do. Or are we tired? Are we tired? Okay, so we have one. Okay, two. Alan, two. Okay, three. So we'll start from this table.
Okay, thank you for the opportunity again. It's a very interesting presentation and very educative. Talking about the polio issue, you pointed out in northern Nigeria. And I'm happy in your advances you qualified that. Is very good. I just want to make a remark on that one. You see, when polio vaccination came in, it didn't take into account the social structure issues on ground. I happen to be the program officer for a project on advocacy for reproductive health launched by the David and Lucille Packard Foundation far back in 2000, 2001, 2002 in northern Nigeria on family planning. And we all followed a similar pattern. At the beginning, we failed to recognize the social structure, the cultural settings, and later we had to bring in the traditional rulers, the religious leaders who had to make sermons in churches and mosques and so on and so forth. And today, family planning is a talked issue all over northern Nigeria. The same thing with the polio. The entry at the beginning was a problem. Not that people are ignorant about they may be ignorant, but the project didn't take into account the structure, the social structure, and the religious settings. And in line with that, you brought up this issue of you also in South Africa. You know, the whole of Africa, the cultures are similar. And I'm happy you brought in social programs that change behavior, which made you to succeed in trying to eliminate ignorance about the importance of vaccines. So it's a very good presentation. Well done.
Charles, thanks for your presentation. I was trying to link your presentation with the previous one. And I mean, we're talking about 100 million US to invest into building vaccines in Africa. And we know that unless we get the buy-in and we engage the public sufficiently, stuff like that might not work. And so I was just curious, do you have an idea as to how we scale up community engagement for vaccines and vaccine production and people's perceptions thereof, if we are to have this roadmap that's going to attempt to put vaccine production on the African continent?
Thank you for that. I think it's very important to understand more on vaccine hesitancy, so I'm glad to hear that you have students working on that. To follow on the last speaker, one of the issues in the last Ebola outbreak in West Africa was the mindset of some of the people. I worked in Conakry whilst the WHO was working. You would have teams going into communities and using chlorine, hypochlorite, as a disinfectant. And some people were actually saying that the teams were actually spraying Ebola onto them. So there is a major issue with the way our people understand some of these modern tools that we say, is for their benefit. When they think that, the diseases that are worrying them are due to other aspects, okay? You know that in Nigeria, there was a major problem with the polio vaccine before because some religious leaders said they believed that the polio vaccine was associated with HIV spread. So that is a very important question that he's asked you. Because if you don't have the efforts that you're doing alongside, our advocacy to scale up vaccine, and coverage goes down, immunization coverage goes down, then we're going to have the disease coming up. Okay.
Good afternoon. My question is a bit similar to that of Professor Alan. What effort are you doing? Vaccine hesitation is increasing more than before. I think it was last month I read an article about a soccer team guy in US who refused to take the vaccination and who was suspended from the team, and his parents insisted that he will stay home and maybe he will get immune on his own. He will rather stay home than go out. And we are talking of those are advanced countries. How much more here when the people who know a lot. So what are you doing to the average Nigeria, our buying? If you buy into that, it will go a long way. Thank you.
Thank you, and thanks for that beautiful presentation, especially seeing the social aspect of that. Mine is not a question, but just to comment on what is happening. I think, and this also has to do with issues around funding of the kind of work you do. You come out with this excellent understanding of what is happening based on systematic review meta-analysis, and it is clear within the African continent or whatever continent it is that to get to the grassroots, it's not the academicians and it's not the biologists, it's not the lab people that get into those spaces. It's not even just the healthcare workers. You have a whole system of community-based organizations, NGOs that can do that work because their expertise. You have all the policy documents around the world that keeps acknowledging this. But when the fund comes, it goes to the ministry, it goes to the researchers, and then you ask the CSOs and the CBOs to go and look for the fund. And I don't know when that paradigm shift is ever going to happen. All the funds and donor funds, they will go into the ministry because it means that is how they get the buy-in. And the US funds go to the ministry and helps them buy tables and paint walls, and the community is supposed to work. So how do you, in your work, help to change the paradigm of support to really get things going? Thank you.
I thank you for your excellent presentation, and I'm wondering whether there's also the issue of fake news that has hit the US and Europe quite hard when it comes to vaccines, and if at all this is tackled, that there are even some sort of media campaigns from certain groups that target on the level of fake news in spreading wrong scientific knowledge about why a vaccine should not be used, and that can also, for instance, explain the decrease in the effectivity of measles as the latest one. And your New York example showed that. Thank you.
Before I answer, I don't know, Abdu, I don't want to put you on the spot. This thing about community engagement and all of that, with your recent experience in Kano, in your study. Do you have anything to say about to contribute to that, or maybe you say that when you are doing your presentation tomorrow?
Okay, so I think I'll just shed more light on it tomorrow. Yeah, I'll shed more light on it tomorrow. But our work was basically. Oh, okay. Yes. So our work was basically with health facilities and working with a lot of healthcare workers to actually co-design interventions. Yeah.
So that was involving but most of these questions that we're saying now, that was just to show that there are reasons why we have low vaccination coverage might be multidimensional. Some of it might be related to healthcare workers. Some of the reasons might be related to the health systems. Obviously, the vaccines need to be available. But some of it also has to do with the community. And I think that the questions that have been asked or the comments are actually very related. And just to start with the initial comment, just demonstrating what we have all said here now, that if you don't involve the community, what we tend to do is we believe that we have something good for them and they must just accept. But they need to understand. We need to bring them along, which is the community engagement. It's very important. And no one group can do that alone. We know the ministries of health, the departments of health, like when the money comes, it goes to the departments of health because they want country buy-in. But then they need to involve everybody. Like what happens with the Gavi health systems support, there needs to be multi-sectorial engagement. You need to have civil societies involved, have community-based organizations involved, and I think we cannot overemphasize that. What we do as researchers is only to synthesize the evidence, show what is important, but also we also have a role is that this information doesn't have to remain with us. We need to share and be able to synthesize this evidence in a way that is palatable, easily digestible by the people who make the decisions, and ensure that there is an involvement from the various communities. And this kind of work, like was indicated, doesn't always have, even the research itself doesn't always have the funding. When you do things like systematic reviews, this is not the kind of thing that is palatable or sexy to the funders. They want to see primary research, collecting data, and most often just repeating the same things. But I think it's very important, the synthesizing the evidence, very important, the engagement with the communities. And I think we all have to play that role. Us as researchers, we do collaboration with departments of health, ministries of health, and also the civil society. We also, there's now with the vaccine hesitancy, a lot of it now with the social media. 5 years ago, I'm not sure that we could imagine how the power that social media was going to have with WhatsApp, what is happening now. Everybody is on their phones all the time, and a lot of false information is going around in all of that, and we need to find ways of counteracting that. We know something has happened already now where the biggest, these big social media groups, they have now have some kind of buy-in in order to fight vaccine misinformation. But it probably needs to go beyond that. Maybe we need all the technology service among us need to develop some bots that are going to fight this misinformation. I think it is everybody's business. And all the comments, I think most of it they were just comments and emphasizing why it is important to engage the communities, understand what their issues are, and let them partake in the designing of the immunization programs, the schedules for the immunization programs, and when it is going to be delivered. And in that way, it's going to work better. I think that's all I can say now, but it's just to say that all the comments that you've made, they are going to inform some of the work that we do, but I think it's also going to, some of the work that we do, our group collaborates with various, for example, I just finished my term at the Strategic Advisory Group of Experts on Immunization. I'm still involved with a few other groups, and some of this, we also share this information to ensure that it's not a one-size-fits-all. What works in Nigeria might not work in South Africa or in Cameroon, and that we all need to be involved. Thank you very much. I think it's lunchtime. I was spreading rumors about you.
Okay, that's how they spread rumors about polio vaccines. Okay. So we've come to the end of the presentations for this morning. I think all the presenters, they did justice to their presentations, and we have been well enriched, and we've also have questions that some of us might want to take further to conduct some research into, which I also think is the essence of this conference. We've also seen opportunities for collaborations, and even the opportunities that climate change presents us with, and even all the development deficits that we have. So I think we're ready for lunch, and we're in good time for lunch. There is a slight adjustment to the agenda. We were supposed to have a panel discussion after the presentations, but because we didn't manage time well today. Sorry, this is not mine, and the pages are kind of distorted. So we are moving the panel discussion till after lunch. Now we'll have lunch and poster viewing in 2 rooms. There is Obecha B on your left, the last room if you're going towards the security exit. And then the Tamarind B on the right. So you have the two rooms facing each other where we'll have lunch today. I hope you still have your lunch tickets with you, because you have to present your ticket before they will allow you in. So we'll come back. So that will be for an hour and a half. We'll have lunch and we'll view the posters. Do enjoy your meal. And let's come back here by 2:30. We are starting 2:30 on the dot of 2:30. So please go have lunch. Please interact. Ask all the questions you may have. Share all the ideas, your research ideas. See how we can, have some cross-pollination of ideas